I just introduced myself. My name is Mervyn Morgan. I'm from the UK ITP Support Association. With us tonight, we've got Professor Adrian Newland, who is also the Chair of Trustees of the ITP Support Association. And in addition, we've got some other board members of the association here. Trustee Derek Elston. We've also got Mr. Anthony Hurd, and we've also got Senior Patient Supporter, Miss Rhonda Anderson. Now, normally with these, if I ask if anyone's got any questions, they haven't right at the start. So hence why I asked everyone if they've got any questions, if they would like to send them in. So I've got a question here, and it's from Dr. Mike Smith. Mike, are you around? Yes, I can see you, Mike. You're on mute. The question is, I'm a retired doctor, and a first-degree relative of mine, age 59, was found to have a very low platelet count in the 1990s and was diagnosed with ITP. As a result, she had her spleen removed in 96. Since then, her platelet level has been fine. She had her first AstraZeneca jab with no side effects on the 23rd of January and is now being offered the second one next Tuesday, the 13th of April. What, if any, are the likely risks related to a second dose based on the facts we know at present? Adrian?
Well, the fact that she had her spleen out over 20 years ago and had a normal count since then means she's cured. She doesn't have ITP. I think we can be quite clear about that. The risks of the platelet count falling following an immunization in a normal person is really pretty low, probably 10 in a million. And then it's usually mild and transient. We've been recording from the Patient Association. We did this survey asking people about their response to immunization. And out of the first 204 or 5 I looked at, the count went down in 10. And only one of those was severe, and that person started with a platelet count of 26. So if it had been 86, it wouldn't have caused any problem. But it did bounce back up again. Funnily enough, we found the platelet count went up in 5 of the patients as well, which is something you can explain in terms of the reaction that you have. The reaction to a dose of either the AstraZeneca or the Pfizer, which are the 2 main ones, the Moderna one, which has only just started this week, the reaction rate's about 1 in 10. And those are the sort of chills, fevers, sore arm, that sort of thing, that are usually pretty transient. And I'm sure what will come up later is this issue of thrombosis. Now, all the cases of thrombosis that may or may not be related to vaccination have occurred after the first one. There have been no recorded cases in the 5 million or so patients who've had 2 vaccinations. So if someone had a first vaccination without a problem with a normal platelet count, I can see no reasons at all for not having the same vaccination, the same product, and having the second one. I mean, perversely, we know that actually the overall clinical results with the AstraZeneca vaccine are actually marginally better than with the other 2. So it's clinically a good one to have. I mean, you get what you're given, actually. It's the one I happen to have, not by choice, although I probably would have chosen it, being a Brit. But I would say, in answer to Mike's question, I see no issues at all with his relative of having the AstraZeneca vaccine as her second dose, having had no problems with the first dose.
Mike, any questions on that? You happy with that answer?
That's great. It answered everything we need to know. Thank you very much, Adrian.
Thank you very much, sir.
Thanks, Mike. Nice to see you.
And you.
Okay, I've got one from Mark. It's on a similar theme. Are people with a pre-existing low platelet count from ITP thought to be at a greater risk of the rare clotting side effect from the AZ vaccine? The reporting I've seen hasn't made it clear if those affected have been people who typically have a low platelets or typically normal platelet levels, which have then been decreased acutely after the vaccine. So,
well, as far as I can tell, looking at the data, none of the cases of this CVST, the cerebral venous sinus thrombosis, have occurred in patients with ITP. They've all occurred in patients with a normal platelet count, and the platelet count has fallen slightly because of activation. The platelet count doesn't seem to fall to the sort of levels that you see in a severe ITP. It just means it falls below 150, so it's below the normal range. So there's no evidence that having ITP makes you more likely to develop this cerebral sinus venous thrombosis. The platelet count falls in that condition because there's some activation of the platelets, possibly related to the vaccine. We don't know that yet, and I can expand on that later if need be. But for some reason, the platelets are activated and they clump and cause a clot. But those cases have all been in normal patients, in normal people. The incidence rate is about 5 in a million post-vaccine. In fact, the rate, although it's very difficult to get the figures in the normal population, but the rate is between 4 and 16 per million per year in the normal population. It's slightly higher in those less than 50, and it's slightly higher in women. That's what we know so far. There's been no instance at all, as far as I'm aware, of someone with ITP getting it.
okay, has anyone got any questions I'd like to add? Just put your hand up. Patricia, you're on mute, Patricia.
Well, I tested after my vaccination. So 3 weeks ago, I tested positive for COVID, and so I wasn't allowed on the plane. But what I've worried about is I've rebooked for May the 5th. But I've heard that when you test positive for COVID, that can sometimes be up to 90 days and still be tested positive. Do you know anything about that? And I think my platelets, they're about 30.
You had your immunization, your vaccinations, have you, Patricia? Did you say?
Yeah, I had the first one. I've now had the second one, but after the first one, which was the end of January, and then beginning of March, the first day they said I was negative, and the next day they said I was positive for COVID. And so the NHS called me every day for 10 days to make sure I was isolating. So I had to cancel the plane trip because I was suddenly positive. But now, if it's true that up to 90 days, I could still remain positive. And so I'm really worried about that.
And that was positive through the throat and nose swab using the PCR test, was it, as far as you're aware?
Yeah, with NHS, and NHS isn't covered for the airlines.
You may remain positive, but it's not necessarily likely. If it was early March, that'll be 2 months away, and the chance of still being positive then are negligible, to be honest. I mean, I can't say it will be negative, but it's more likely to be negative as it drops off quite quickly. Your antibody level will be pretty high because people who've been vaccinated and have got the infection have a sort of super antibody response to that. But I think you illustrate the case in point that the vaccine isn't 100% effective, because nothing's 100% effective. It's probably effective in the low 90%, but we certainly know from the figures that those who develop COVID, having been vaccinated, have a much less severe disease that clears much more quickly, probably because of those antibodies that are present that mop it up and clear it. So I can't say positively one way or the other, but I would think the likelihood is that you will be negative at that stage. I mean, you can certainly go and have I mean, once you've done, you're presumably well past your quarantine period. So there are places that you can go and have the test. You can just walk in. I mean, I know the centres around London where you can go and have it done, but I suspect there will be places locally where you can go and have the test done. And the PCR test is probably more accurate in terms of telling you if you've got an infection. This lateral flow test, which is the one that's done, that you can do yourself, which is more of a screening test, is more likely to miss infections. But the reason it misses them is because if the infection is at a very low level, it's not that sensitive. And someone who's what we call false negative, which means they do have the infection but test is negative using lateral flow, has almost certainly got the infection at a level that they're very unlikely to pass it on or to cause a problem. But if I was you, I'd find your local centre and go along and say you've had your immunisations, you have an infection, you've done your quarantine period, could they test you? And that'll just give you an indication if you're still positive. But it is the PCR test that you have to show as negative before you can fly.
It'd be awful if I'm positive again, then I have to go through the whole thing again.
Yeah.
Yes.
Which vaccine did you have, Patricia?
I had the where's it gone out of my head? You know, the first
Pfizer?
one.
The Pfizer one.
Yes, I had
The one, yeah.
now.
Okay.
Can I ask whether Patricia feels that she actually did have the coronavirus, that she actually contracted it from somebody, or is it possible that the vaccine could actually produce a positive response to the PCR test?
No, the vaccine won't give you a positive test, because what the swab is testing is it's looking for the actual, what we call the antigen, which is the thing that recognizes that the virus is there, whereas the vaccine produces an antibody and doesn't have the vaccine, doesn't have the antigen that you could pick up. So she would have had, that would have been a true positive. I was going to say something else then, but my brain's gone.
Okay.
These things happen.
I saw a few other hands up. Any other hands on the question? Kath at the top. Kath Warren, you're on mute.
Yeah.
There you go.
Hello, I'm Kath's husband. My name's David.
Okay, David, go ahead.
We've got a 30-year-old son who has ITP. His platelet count sort of moves between 40 and 50-ish. He hasn't had, obviously because of his age, his first vaccination yet. Now, we came on this to try and understand what potential implications as far as his platelet count were, as far as the impact of having the vaccine. But if I understand this condition correctly, low platelets means it's more difficult for your blood to create blood clots. Is that correct?
It's partially correct.
Or if you cut yourself, it's more difficult for you to stop bleeding.
Yes, but we do know that patients with ITP are slightly more prone to have thrombosis, to have clotting. But yes, you're right. If you cut yourself, you will bleed for longer.
Right.
But
So if you've got if you've got a lower platelet count,
yeah,
why is it easier for you to get a blood clot? That's what I'm trying to understand.
Are you talking about these blood clots and slightly lower platelet count that's in the media at the moment?
Well, if you've got a platelet count of between 40 and 50,
yeah,
which means it's much harder for your body to stop yourself from bleeding, actually form like a seal over a cut or whatever. How is someone more at risk of getting thrombosis?
Well, in ITP, in general, you're destroying platelets, and so therefore you're producing more. And younger platelets are slightly more effective in leading to clotting than ordinary platelets. So patients with ITP have a slightly increased tendency to develop clotting. I mean, it's not common, but it's slightly more common than someone with a normal count, bizarrely. So these are sort of deep thromboses. These are the DVTs or the pulmonary embolisms or things like that. These aren't the issues relating to stopping yourself bleeding if you cut yourself.
Right.
So we know just from comparing a large number of patients with ITP compared with a normal population, that the instance of thromboses are slightly more common in patients with ITP than they are in the normal population. And this is also made worse in patients who had splenectomy, in whom thromboses are a little bit more common as well. But
Right.
You're right, it's this sort of bizarre mixture that in general you're at risk from bleeding when the platelet count is low, but that doesn't stop you in certain circumstances having a slightly increased risk of thrombosis.
Right. So your body is sort of working overtime a bit to produce more platelets to compensate, but
Yes.
then your immune system is killing a lot of them off.
Yeah, so it's a sort of, they're being removed at one end while they're being produced at the other, and it's the balance of those depends what your count is. So if you're destroying them more quickly than you're producing them, your count is very low. I assume that your son is sort of more or less in balance at the moment.
Yeah. Right.
Yeah, destroying them slightly more than he's producing them, so it isn't normal. But in those where you can stop the destruction, then you produce back up to a normal level, and then things stabilize.
Right. So is the risk of thrombosis only linked to the AstraZeneca vaccine, or is it general?
No, it's general. I looked at the MHRA website, which some of you may be aware of. That's the medical regulatory authority that approves drugs in this country. And so anyone who's got a side effect should fill out a yellow card and send it in. For the first, I'll read this out, for the first 10 million AstraZeneca vaccines doses, 28 reported some sort of thrombosis. For the Pfizer vaccine, 25 reported the same thromboses for 11 million vaccines. So the rate of thromboses was actually pretty much the same. But you've got to balance that with the rate of thromboses in the normal population is about 2,500 a year. That's, we would anticipate in someone who's less than 40, the rate there is about 1 in 10,000, but that's still about 600 thromboses a year. So in the 3-month period from January to March, that's something like we would have expected 600 thromboses in the normal population. So what we've seen here is 50 in the 20 million people who'd been vaccinated over that period. So there's probably some association with the vaccine, but whether those would have happened anyway, we just don't know.
Yeah, understood. All right, thank you very much.
Thank you, thanks very much. Right, any other, Michael Smith?
Yep. It's somebody who's had their spleen out. Is it still recommended that they take a small dose of penicillin every day?
I say yes. The chief medical officer's advice post-splenectomy is you take a dose of penicillin daily for life. We're the only country in the world, as far as I'm aware, that gives that advice. It used to be, until they said that, which was pretty much 20 years ago now, we used to give it for 3 years, which is where the main risk factors are. What our advice is that you should take it every day, but most people forget and thaw after a while. But if you had your spleen out, your platelet counts back to normal, and you have no problems, you're not on any drugs, you're not on any risks, then if you've taken it for 3 years, the thing to do then is to keep a supply of antibiotics at home. And if you have a temperature and a cough, you produce phlegm, then you take an antibiotic. If you can remember to take it, that's fine. If you're still on steroids or immune suppressive treatments, then you probably ought to continue with antibiotics because it increases your risk. The advice from the chief medical officer really was related to other diseases where the spleen is taken out and people still are what we call immune suppressed. Whereas a patient with ITP whose spleen's taken out, who's normal, isn't immune suppressed at all. The spleen is only a third of your immune system and the rest takes over. So you're not immune deficient once you've had your spleen out. It's useful for many things, but your body will take over. You produce antibodies in a pretty normal way.
When you said we're the only country in the world, I mean, I know in America it's not recommended, is it, for instance, but there are many other countries too where it's not recommended.
Well, I think they all recommend it for a period post-splenectomy,
Yeah.
but I think we're the only country that recommends you take it for life.
Thank you very much.
I can't remember to take a full course of antibiotics.
Would you like me to come in there, Adrian?
Yeah, please do, Rhonda. Yeah.
Okay, I'm Rhonda Anderson. I'm a patient mentor for the ITP Support Association, for those people who don't know who I am. And I had a splenectomy in 2000, and I was in hospital for 6 weeks because my platelet count was very obstinate and it was down about 0 most of the time. So when I actually had my splenectomy, I only had a platelet count of 8, which they were all pretty worried about. But anyway, yes, it sometimes depends on your doctor, because when I first, had my spleen out, I was actually taking penicillin V for a long time. And then I said to my doctor, having gone to ITP conventions and so on, I don't really want to be taking these for the rest of my life. And she said, oh, you must, you must, you must. And then I got a different consultant. She left and a different consultant came along, and I said to him, look, I don't want to be taking these. And he said, that's okay, don't take them. So I haven't been taking them, but just as Adrian said, I do have my supply of antibiotics. And I occasionally have had to use them. It's usually when I'm on holiday in some far-flung country and I'm feeling a bit seedy and wondering whether I'm going to develop anything horrible. So I have taken them, I think, on about 2 or 3 occasions, but in 21 years, I don't think that's too bad. So I just get them prescribed by my GP, and I do actually still have a blood test once a year. If I haven't had it done for something else, then I have one done once a year. But as Adrian says, I'm not really worried that I'm going to relapse having had a splenectomy, but one never knows. Something, perhaps if I'm very fortunate I haven't had COVID, but perhaps if I had got COVID, something may have happened, but then it may have happened to a person who's still got their spleen and who never had ITP anyway. So I think the important thing is to be vigilant about your health, but not to worry about it too much. And
thank you, Rhonda.
Yeah, okay.
Can I just come in? There's a question there about whether you can refuse the vaccine. Well, anyone can refuse the vaccine. You don't have to turn up. If you're over 30, you would tend to be offered the vaccine that's available. You don't have a choice. You can't say, I don't want this. I mean, you can wait, and you may get the other one if you wait long enough. What I would say about waiting, about refusing it entirely, the rate of COVID deaths is 40 per 100,000. That's 400 per million. Now, the case of these special brain hemorrhages, of which the death rate is only about a quarter, is 5 per million. So you're balancing a risk of death of 400 with COVID. And of course, the risks with the vaccination are when you have the vaccination. If you don't have the vaccination, the risk of death is every week. And I put it in the thing that Mervyn put out for the association. It's been calculated that your risk of dying of COVID is 2 to 3 per million per week, every week that you delay the vaccine. So it's a no-brainer, to be honest. The risks of dying from COVID, the Joint Committee on Vaccination and Immunisation, which were put out the data yesterday when they were talking about the vaccine, was putting an element of risks and balances. And in the 60 to 69 age group, the risks of harm from vaccine is 2 per million. The number of people who have been saved from going into an ITU who've been vaccinated is 1,300 patients per week. And over the period of the 30,000 vaccines that have happened in this country, they reckon that saved 6,000 deaths.
That was a really good slide that Professor Van Tam showed yesterday.
That was a super series of slides, and I think
will try and get copies of them and publish them on our website. They were really interesting.
Yeah. And one of the reasons why they've said 30 as the cutoff point, the risks of the vaccine in the younger person are slightly greater from thrombosis for whatever reason, but that's about 10 per million. The risks of ending up in an ITU or being saved from going into an ITU is something like 70 per million. So it still balances, but of course the risks of COVID in the younger age group are much less. They can still pass it on to people around them, and there are still the risks of what's called long COVID. This is the problems that patients have, which it's estimated there's something like 1 million people in the UK now who have this long COVID condition. We don't know how long it lasts. We don't know necessarily what to do about it. But the balance of evidence for serious infection or thrombosis against the benefits of having the vaccine far outweigh the benefits of having the vaccine. And the reasons that they've chosen to say we won't give the AstraZeneca vaccine to those under 30 is just that the balances are still in favor of having it, but actually then so much less than if you're older that they thought we may as well give them one or the other, which isn't as yet associated with this cerebral venous sinus thrombosis to the same degree. But it has been described in all of them, but in much, much lower numbers. I mean, like 1 per million instead of 5 per million.
Thank you very much, Adrian. We've got more people to hand up. Marvad, you got your hand up?
Hi.
Yes, sir.
Hi, got a question. My daughter suffers from ITP and her platelet goes lower during Easter time. Now, she had a vaccination on 18 March, which was Pfizer, and her platelets has dropped. Is there any connection between the vaccination and the platelets?
The platelet count from our numbers, probably in about 5% of patients will dip post-vaccination.
Okay.
It's much less in normal people, but it happens. We know that it happens in the normal population as well. But there is a small drop associated with vaccine in a small number of patients. It's generally fairly mild and it's generally transient. It occasionally requires treatment just to boost it, but in general it doesn't. And certainly my advice to patients, if their count's generally 50 or above, then I don't worry too much about a vaccine. If it's 20 to 30, then I would tend to suggest discussing it with your GP to see if it's worth having a boost of treatment, either a very small dose of steroids, which won't interfere with the vaccine response, or a small dose of one of the thrombopoietins. And the one I have suggested is the Eltromopag, purely because it's a tablet. But I think it's worth discussing with the GP if the platelet count is lower, sort of anything.
Yeah. Just to qualify, it was her second dose,
Yeah.
second vaccination, and her platelets were 16.
When after the vaccine?
Yeah, after the month, yeah.
Well, if certainly it depends. That will bounce back up again, and if she had no bleeding, then you would do nothing about it with a count of 6. So I would be quite relaxed about a platelet count of that level, because it drops down and comes up again. Even in normal people, it may drop by 10 or 20, which of course you wouldn't notice if you were if you were going to have, unless you checked it. And I think the vast majority of the patients who took part in our survey who had the vaccine, the majority had no problems and didn't have a count. So we assume that whether the count fell or not, we don't know, but it didn't fall to any level that caused a problem. And of those that were checked, there was a fall. I think it was about 5%.
The latest survey results we've had, because we actually changed the survey about 3 weeks ago. We've had probably 120 returns so far, and of those, 8 people's platelet counts went down, but 13 people, their counts went up. So it's you tell me. So I don't know. So yeah.
Well, the reason
Lisa
for
Mills.
that, I should just come to that. Those who've had the vaccine, who may have had their sort of slight temperature or sore arm or whatever, it means the body's reacting to it, and your body, when you react to something, produces a bit of steroid, sort of hormones we call cytokines that all stimulate the bone marrow, and that may stimulate the platelet count to go up, and that's why it occurs. And again, that's transient. Within a week, 10 days, it would be down again to whatever level it was.
Can I make a comment as well about low platelet count? Mine went from 180 down to 8 in a fortnight after I had the vaccine, and then I had other problems afterwards. But the reassurance for a lot of people over the last 10 years, I've had platelet counts of 1 or 3 on at least 7 occasions, and apart from some bad leg bruising and some nose bleeding, I've not had any other side effects.
That's a pretty
another thing I want to come back to. Sorry?
I said that's a pretty spanking fall. Have you filled in our survey?
No, not yet. I've had a lot going on at the moment because I've been diagnosed as being a medical oddity, which you might already have heard of, Dr. Newland, but I'll come on to that later.
Okay. Well, please, when you've got time, fill out the survey. It'll be there, because I think we want to capture whatever data we can.
Okay.
Thank you, Karen. Lisa Mills, you've had your hand up for a while. Lisa?
Hi everybody.
Hiya.
Thank you very much for taking my question. I had my splenectomy 30 years ago. My platelet count has been steadily between 400 and 450 for all that time. And my question is to do with the raised platelets. If the vaccinations lower platelets, mine can afford to go a bit lower. But in some cases they are raising them a lot, and if it raises that even more, does that make me more susceptible to thrombosis?
The answer is yes, it could do, and even at 400 to 450, there is a risk of that. Particularly if you have any other risk factors. We sometimes suggest that people who run to that level take what used to be called a junior aspirin at 75 milligrams per day. But obviously, it's the sort of thing you would probably want to discuss with your GP, because you would know your other health factors. But what I would say is the count actually doesn't go up a lot, so it wouldn't go up to sort of 550, 600, that sort of level, and it would go momentarily up and then come down again. But it's certainly worth perhaps when you next see your GP of discussing it with him or her. Yeah,
I've booked for a platelet blood test to see what my count is. I've had my first AstraZeneca vaccine 3 days ago, so I'm going to see what happens to it. The other part to the question is really, if it does go rapidly up, do I continue with the second vaccine or not?
The response to the first vaccine doesn't necessarily predict what will happen to the second vaccine. So yeah, yes, but if it has gone rapidly up, then almost certainly you ought to take an aspirin until it starts to come down again. And that's
okay. Thank you.
Junior 75 milligram aspirin.
Okay, thank you very much.
Thank you very much, Lisa. Any other questions, people? Linda L. Go ahead, Linda.
Hi, again, thank you, Adrian, for answering these questions. Just a quick one. You just gave me a little bit of concern. I got my AstraZeneca jab about 6 weeks ago.
Yeah.
For the past year, I've been given blood every single week because I'm on M-plate, and my platelets have ranged from about 0 to 25 up to 40, then back down.
Yeah.
Since I've had the vaccination, my platelets have shot up to 210. They've hovered around there, then they plummeted down to 80. Now they've gone back up to 230. And then last week, my platelet count, they couldn't actually do a platelet count because they had clumped so much.
Mm.
Do I need to be concerned that, is that a coincidence? Because I've never clumped before. Is that sign of a clot?
No, the platelets won't clump inside you. They clump because of the anticoagulant in the bottle they put the blood into. It's just a feature of the anticoagulant they use in blood bottles, and if the platelets clump, then you use a different anticoagulant. But it's not. It's something that's what we call an artifact. So it's not a biological thing that's happening inside you. So just because they clump in the bottle doesn't, or on the slide, doesn't mean they would clump inside you. So you don't have to worry about that at all. But I have to say, the story is very interesting with it whizzing up and down like that. We see that with rifamycin quite often. I mean, a small number of patients on rifamycin do often have these wild swings, and sometimes you can't stabilize the count at all. But so it'll be interesting to see what happens over the next few weeks if your count then stabilizes and goes back to what it was.
Yeah, thank you for that. I was just, I panicked there a little bit when I thought,
No.
have I just clotted and not realising it?
No, I'm sorry if I alarmed you. Yours is a very unique. About 1 in 800 people have this phenomenon where the platelets clump when you actually take them out of the body.
Yeah, no, it's only, I've been given blood for the whole year. They check my blood every week before I get a plate injection. And it just so happens after the vaccination that they clump. And you just mentioned clumping, that's why I got a little concerned there. But thank you.
It's quite an interesting phenomenon. And as a junior, we tend to try and teach medical students, but they never listen to these sort of things, is that it's a common fault and something you have to look for. If a patient presents with a low platelet count, the first thing you should do is check whether they're clumps. And many, many years ago, I probably had hair then. One of the most embarrassing things I had was a patient who presented with a very low platelet count, and I went through the whole business of telling them what was wrong and what we were going to do, and checked the count, and it was normal. And that's because we took it into another bottle and the platelet count was completely normal. So I had to go back and grovel and say, look, I'm terribly sorry. There's nothing wrong with you. It was our fault, or the bottle's fault. So don't worry at all, Linda.
Thank you, Linda. Karen, you got your hand up again?
Yeah, well, I'd like to ask Dr. Newland, have you had any instances of patients who have had rapid increases in their platelet counts? So a fortnight after the vaccine, my platelet count was 8. A week later, it was 280. The following week, it was 640. So I stopped my romiflostim. A week later, it's 480, so I'm still not taking any romiflostim. I said about being a bit of a medical odyssey. I don't know whether you've actually heard about me, but after being really unwell for most of last year, and various reasons being given for my high white cell count from July onwards, I was diagnosed with chronic myeloid leukemia, and my consultant is unable to find. He's even got the junior doctors searching worldwide for any medical references to anybody else who has ITP and chronic myeloid leukemia. It's lucky that they caught it early, and I'm on imatinib. I'm just really interested in what's happened to me since I've had my coronavirus vaccine.
I can't truly answer your question, but I have seen patients in the past with leukemia who've had ITP, very small numbers. There's no association between the two conditions at all. It's purely happenstance that it occurs.
Yeah.
Whether there's some reason, we know that on romiflostim the count can suddenly swoop up. What it means is that your body, for some reason, has stopped destroying the platelets at the rate that it was. So the stimulus of the romiflostim to the bone marrow is suddenly unchecked, and the count, which has been striving to go up, but you've been destroying them as well. You've stopped destroying them and the count's just gone up. I can't explain why that would be, whether it's related to the vaccination or whether it's related to the CML or whether it's related to something else. I can't answer that.
They're pretty sure it's not related to me having been on imatinib for 2 months with very little change in my platelets. But it was only after I had this rapid drop after the vaccine, and then this, sort of skyrocketing.
Yes, I mean, interesting enough, in chronic myeloid leukemia, all elements of the blood get increased, and the platelets are often quite high as well. And what the imatinib, which is the specific treatment that will bring the platelet count down. But that's an impact on the bone marrow production of cells, not to anything else. It's not something I can explain.
Thank you.
Okay, thank you, Karen.
Right, could I just say here
on,
that
Rhonda.
I had a virus once when I was on holiday, and I went to see my hematologist, and I thought the platelet count would have gone right down. In fact, it had gone up way over 800. And I had to take aspirin, as Adrian was saying, for a while. And he said to me, I saw the man himself, and he said to me, oh, he said, I was going to discharge you today, but since you've got this really high count, I'm going to have to see you again. And so anyway, I went back again in whatever time it was, and it had gone back to normal. That was post-splenectomy. So, and he couldn't explain, nobody could explain why the platelets had gone way up over 800. I mean, I was really surprised.
Yes. I mean, when you have an infection, the body produces all sorts of things. Part of the body's reaction to infection is you produce lots of chemicals. You produce more steroid, you produce adrenaline, which is part of the sort of fight or flight reaction. So there's a lot of things that you produce, particularly if the infection is more severe, that can impact on the bone marrow. And we do occasionally with severe infection see the count bouncing up. We also, with infection, see the count plummeting as well. And you can't predict what will happen, but both have been described. There's a question here from Renee about who had ITP due to flu vaccine 7 years ago, where the count dropped significantly and required treatment. That sometimes happens. It's very rarely, unless there's an underlying basis of ITP that hadn't previously been picked up, it's normally transient and the count comes back to normal. We don't normally recommend not having a repeat vaccine. I don't know if she's actually in the last 7 years had the flu vaccine again, but we would normally recommend it. But actually, I remember what I was going to say earlier when my brain went blank a while back. The flu vaccine, in comparison to the COVID-19 vaccine, the flu vaccine only works in about 60% of cases in a good year. So although we recommend it, you have that on a yearly basis, it's actually a much less effective vaccine than the COVID seems to be. And that's because flu produces a lot of variants. They try and produce a new flu vaccine each year, dependent on what flu seems to be prominent. And it's normally starts over in China, Australia, that sort of areas. They see what the type of flu it is there and produce a vaccine accordingly. The COVID-19, although you've seen a lot of stuff about variants, doesn't seem to be quite as unstable as the flu vaccine. And although they will tweak the vaccine, and I'm sure anyone at risk will end up getting a booster on a yearly basis, I think there'll be less of a problem in keeping the effectivity of the vaccine than is currently expected from the flu one.
Okay, thank you, Adrian. Renee, you got your hand up?
Hi, yes, I asked a question, sorry, about the flu vaccine. I've never had the flu vaccine again because I was worried that it would reduce or bring me in remission for 7 years. I had a blood test last week and it was 144.
Yeah.
So just a bit worried that if I have this COVID vaccine, I'm going to go straight down to 0 again. The doctors are saying just monitor yourself. They're not really offering like blood test or anything to take after the vaccine. But at this stage, it's kind of, I don't know if I want to go back down to that again.
Well, just because you had a reaction to the flu vaccine doesn't mean to say that you'll have a reaction to the COVID vaccine. At a count of 144, I would certainly see no reason for not having it. You've had it depends when you have it. I would certainly have a count before. I would then about 10 days afterwards ask to have a repeat count. And if it's fine at 10 days, you'll be fine.
Okay.
As I was saying earlier, the risks from the infection are far greater than the risks from the vaccines, either from a lower platelet count or from the thrombosis.
My platelet count went down to 8 after the vaccine, and
Yeah.
I would take the vaccine any day, having lost a close friend to COVID. The risks of COVID are just too great. I mean, you know, just if you have a reduction in your platelet count, if it needs dealing with, it needs dealing with. But the risks of COVID is too great.
And it is not a pleasant disease to have. I mean, 50% have it without having any symptoms whatsoever, and about 10% have it severely, and about 20% will have sort of moderate infection. And it's not a pleasant infection, and a significant proportion will have this potentially, I think it's 4 million infections of COVID so far in the UK, and there are 1 million patients with long COVID. So even if you get over the initial infection, even if you have no symptoms, you still may get an issue with long COVID. So it's worth, I think unless there's a specific reason for not having the vaccine, then it's worth having it. And if you're worried, you should talk to your GP about it.
Okay, I've got a question here, non-COVID related. The question I'd like to ask is, have you ever had a patient in the past who's had 3 acute episodes of ITP, i.e. 5 years apart, you know, each time, where they've been hospitalized for 1 or 2 weeks with platelet counts of 0 or 1, and then they've had nothing since? It's just gone for no apparent reason.
I mean, ITP, as I'm sure the majority of people who phoned in will know, that it's a very strange disease. It's very rarely cured. It may be cured by, in some patients with splenectomy. We know that patients who've been on thrombopoietin, a percentage, can go long-term off all treatment. And we know, I mean, I'm talking about adults here, not necessarily children. And we know it can be quiescent, but essentially it's a condition that may return at any time if there's a challenge. And so we've certainly, I wouldn't say it's common, but we've certainly seen within our unit, because we actually follow up a lot of patients, where you'll have people who are stable and they may get an infection or something may happen. We don't even know what it was, or they may have taken some sort of drug or chemical or whatever, that suddenly dropped the count down and has required intervention. That goes back up again and things are stable. I think that's what chronic ITP is, that it's a disease where the platelet count sits at a level that may be normal or maybe less than normal, and periodically there may be a fall for whatever reason. It drops, it may not require treatment, but sometimes it drops to a level that requires treatment. And what treatment should be doing in these instances is push the count back up to a safe level, and then you wait and see what happens. And the vast majority of patients will go back into a stable state again. So yes, you can get intermittent bouts of acute thrombocytopenia years apart if necessary, because your body is still primed to react in that way.
Thank you very much, Adrian. Anyone else got any other questions? Kay?
Hi, I just wanted to ask about vitamin D, because I've been taking that for quite a while now, and I've read recently that there can be a connection that it can help with regards to COVID. Is it advisable to take this all year round, or do you need to stop it, you know, when the summer weather comes in, or could I take it all year?
Okay, can you tell me from your accent, do you live in Scotland?
Yes, I do.
Vitamin D all the way around.
Right.
No, I mean, yes, I mean, I'm sure Anthony and Rhonda may want to talk about this as well. I mean, I take vitamin D. My wife and I take vitamin D on a daily basis. There's no doubt that vitamin D, which is an interesting compound, it used to be thought it was just related to building up calcium in your bones, but we know it has an impact on bone marrow function, and we know it has an impact on immunity. And although the studies haven't been done in large numbers, there's a suggestion that actually vitamin D does help you fight the COVID infection. So, and actually the majority of the population in the winter become vitamin D deficient. If you're a golfer and you wear short sleeves in the summer, your vitamin D levels will be normal because you get vitamin D from sunlight. That's why I said if you're in Scotland, you probably ought to take it because you don't get sunlight to the same degree that we do. But taking, I think it's 25 micrograms a day or 10 micrograms a day is very reasonable. It has no side effects at those sort of normal levels, and it will help your immunity. And Anthony or Rhonda, do you want to comment on that?
Yes, in fact, it was one of the topics that we discussed in a couple of the other support groups that we've had online earlier in the year. So if people want to discover a bit more about that, you can go to the YouTube channel. I've put the links right at the beginning of this session. If you go to the YouTube channel and have a look at the previous sessions that we had earlier this year, the local support groups for England, Wales, Scotland, and the whole of Ireland. But in general terms, if we're in the if we're all living in the northern hemisphere as we are, we can't produce enough vitamin D from the sunlight that we're getting in winter. It's as simple as that. And unfortunately, it's one of those vitamins that isn't available in many food groups either. So it's not something that you can get any other way but through supplementing it during winter months. So definitely worth doing. I take 1 vitamin D tablet a day. These are Holland and Barrett, but they're available in most pharmacies, Boots, Superdrug, those sort of places. For the sake of sort of £3-4 for a bottle of them, it's well worth doing. I take 10 units, but anything up to the 25 unit tablets are worth taking. For those of us who are on immune suppressing drugs, the government actually here in England, I don't know about the rest of the UK, but here in England, we were supplied them free of charge. You had to apply, you had to opt in, and they would send you some free of charge. So I also got some sent to me by Matt Hancock, I presume. Must be busy stuffing envelopes with vitamin D tablets or something of that type.
It keeps him out of mischief if he's doing.
Yes, it's probably the best, sorry, dare I say, the best thing he could possibly use his time to do. Anyway, never mind, that's all another story. But there
I'd agree with all
very useful.
Yeah, I would agree with Anthony on all of that. And I think also vitamin D deficiency will cause other things like muscle aches and pains and different things like that. So it's actually very good to take it. And it is true that we don't get enough sunlight in this country on the whole. And yet, you know, you've got to, when I go out now, I've got this bit showing and that's all. You know, because I've got a hat and gloves and scarf and everything on. Even when I'm in the garden, which I was doing on Tuesday, it was freezing, but I was absolutely wrapped up like a mummy. And, you know, so you don't get it. And you really do have to make a big effort to go and sit in the sun to get any vitamin D. And you've got to do it early in the day, you know, you've got to do it at the right time and not through glass and all this thing. So as Anthony says, easier to take a pill.
And as Anthony said with his dose and the one I take, there are those doses, there are no side effects. So you don't have to worry about any problems with it at all. And it's a nice small tablet that even my wife can swallow.
Thank you. Kath, you got a question? Kath Warren.
Yeah. Hello. Hi, Dr. Newland. Can I just ask, I'm not a clinician. I've been taking that vitamin for a while, but I'm sure I read somewhere that you need to take vitamin K2 as well for this vitamin D to be absorbed. Am I totally off the mark?
No, you don't have to take vitamin K for that. You can absorb enough vitamin D by itself. You don't need to worry about vitamin K.
Okay, thank you.
Okay. I've got an interesting question here, Adrian, from Mandy. Yesterday, she received a letter from the NHS telling her, according to their records, she's recently been diagnosed with a condition or started a new treatment, which means she's now considered to be high risk of becoming seriously unwell if she catches COVID. The 6-page letter goes on to explain shielding has ceased, but explains the precautions she should take, etc. And I just sort of carry on down. When she first had her first vaccination in February, she presumed it was under priority group 6, i.e. people with existing health conditions. Now she's wondering if it could have been priority group 4 and the clinically extremely vulnerable. She's just interested to know, as an ITP sufferer, should she have been shielding and receiving communications in the past year, because this is the first one she's had.
Well, you don't need to shield with ITP. You don't need to shield with ITP if you've had your spleen removed. You only need to shield if you've had your spleen taken out, if you're on some other drug that may reduce your immunity. If you haven't had your spleen out and you're on a high dose of steroids or at least 2 immune suppressive drugs, then you also are more vulnerable. But a majority of patients with ITP don't need to shield. The government made an error about at the beginning of last year when they said anyone with a splenectomy should shield, and we ultimately got them to agree that a patient with ITP with a normal count on no drugs who's had a splenectomy did not need to shield. So without knowing the background of her, or whatever her medical treatment is, that's the position at the moment. I mean, we had cases of people who had their spleens out 20 years ago and were normal, who were not on no drugs, who were suddenly being told by their GPs they'd got to shield, which is complete nonsense. There's a complete misunderstanding of vulnerabilities.
Mervyn, that was my question. Thank you for asking it. I don't know why my name hasn't appeared on the Zoom thing. It says customer.
Yes.
No problem at all.
First time joining, and can I just say how very informative the group is, having had ITP for 5 years, and other than obviously a yearly checkup with the haematologist that I see, being able to speak to people who have same concerns is very, very reassuring. So thank you for that.
Thank you, Mandy.
I was very surprised when I got my letter yesterday, having not had any communications for the last year. Obviously, I've been very careful. My haematologist told me last April when I last spoke to him that, you know, any infection you're more vulnerable to with ITP. So I have been particularly careful. But the letter that came through yesterday, if anything, it did unnerve me, because it talks about shielding has ended, but I now need to do this. I mean, it's 6 pages. I don't take any medication. My platelet count's normally about 70 to 75. So I don't really know what's prompted that letter to appear all of a sudden.
So Mandy, are you now more reassured about having your second dose in May?
Yes, thank you. The gentleman that asked the question right at the beginning with his wife, it was the connection with the low blood platelets, but being at more risk from the thrombosis or the blood clots, that I couldn't get my head round at all. And Professor Newland, I mean, what a star in the way in which you describe things and explain things. So reassuring. Thank you.
Okay, my pleasure. There was a question that I just saw going through the chat, which Anthony has also answered. Someone asked the question about fatigue, which moves us away from COVID for a few minutes. Yes, there is an association between ITP and fatigue. We picked it up probably about 10 years ago now, where we used to think fatigue was related to the infection that caused the ITP or maybe the treatment, but it became quite clear that some patients would come in and say, I think my platelet count's fallen, I'm very fatigued, because I'm very fatigued. And you put the platelet count up and the fatigue clears. And we don't truly know why, but there's certainly some what we would call physiological reasons why when you've got active ITP, when the count's low, you're producing some hormones that are associated with fatigue. And so, yes, there's quite a clear association with ITP and fatigue. And in the majority of patients, not all, but in the majority, when the count goes back up to normal, then the fatigue clears. That being said, fatigue is the side effect of one or two treatments as well. So there's this sort of balance, but in general, fatigue is associated with the low platelet count in ITP that clears when you respond. But we've had certainly some discussions now with the authorities that fatigue itself may be a reason for treating. So if you have someone with a count of 30 or 40, we wouldn't necessarily treat that if they've got no bleeding problems. But if they're severely fatigued and a count of 30, then maybe we should be considering some form of treatment to put the count up and see what happens. So yes, there's a clear issue with constant fatigue, and of course that does impact on your exercise tolerance. To use a medical term, if you're knackered, you won't be able to exercise very well. It's so yes, there is an association with that. Anthony, do you want to make a comment, because I see you responded to that as well?
Yeah, I recall that the very first ITP Support Association convention that I attended back in 2010, the ITP Support Association had done some good research on proving that fatigue and ITP were linked, and I seem to recall that research and the subsequent report is on the website. So if anybody wants to have a quick look at that, it's not a hugely long read, but the gist of it is that yes, there is a proven link. A number of people out in the hospitals, clinics and medical profession will probably still deny that there is. So it is no bad thing to remind them that the evidence is there on the ITP Support Association website. And I still encounter people that are in denial about fatigue and ITP, but hopefully the more we talk about it and make people aware, then the message will get out there and get across. But of course, the other difficult part for lots of us who are on various treatments is that some of the side effects can be equally debilitating in terms of fatigue, tiredness and lethargy and so on and so on. Yes, I can attest to that on steroids over the years and mycophenolate too. So
you're absolutely right. I mean, the ITP registry at my hospital did this study with the association. It was around 2010, and we found that 25% of patients with ITP had quite severe fatigue. The Americans showed something very similar, and it was published then. You know, another 25% had moderate fatigue, so a significant proportion of patients with ITP were fatigued. And in fact, as a little plug here for the convention, we do have one of the American ITP docs who's going to talk specifically at the convention on fatigue and ITP. Cindy Newland, who's also one of our American advisors on the association. So she talks well, and they've got some interesting data. She's just published a paper on fatigue in children with ITP. But the point that Anthony made, which I was alluding to slightly, is that of course the treatment has side effects as well. So that's one of the reasons why we push the fact that if you don't need treatment because you aren't bleeding and your count's not very low, then it's best to avoid it, because all treatment has side effects, and if you can avoid it, you should do.
Another thing to just throw into the mix, I know it sounds trite and a bit obvious, but eating a healthy, balanced diet is absolutely key to trying to ward off as much as you possibly can the impact of side effect of drugs and the general fatigue you get with these type of conditions. So plenty of fresh fruit, veg, plenty of green veg particularly, and the other big thing is making sure you drink plenty of water.
Yeah, and
being well hydrated, very important, and we neglect that at our peril very much.
And the occasional glass of red wine.
Yeah, that does no harm. Yeah, very much.
Adrian,
Can
just
I make a comment?
go on, Karen.
No, I was going to come in, if I could, on a side effect of treatment thing here, and how one deals when one's in hospital for the day. I had a urinary tract infection a week after having the coronavirus vaccine. So I took the amoxicillin, and a week later, I feel dreadfully unwell and had this awful lurid red macular type rash from my knees all over my torso and down to my elbows. So I was taken, my husband took me straight to the hospital, to the haematology day unit. So I was admitted for the day, and they found my platelet count was 8. But normally when my platelet count is at that level, I might get a nosebleed. I had no bruising at all on that day. I only got a nosebleed after I had to have a COVID test because my temperature went up to 38.2. And the consultant who was on duty that day, they take it in turns to come out from our local, other big hospital to the district hospital. The consultant decided that I was coronavirus possible. So he insisted I have the test. I thought that's fair enough. But of course, that set off the nosebleed, but it stopped in an hour.
Yes, the tests for those who had it isn't necessarily pleasant in that they have to put.
No, I've had it 5 times now. That's quite enough.
Karen,
I've never needed.
Can I just ask, Karen? It was after that, when she'd been discharged, your platelet count went up very high.
Yes.
That was because you had a urinary tract infection that required treatment. That was the response to that.
Okay, that's fine. But this particular consultant, I've had run-ins with him before, because he doesn't like the fact that I was in the NHS for 35 years. And I know quite a lot about ITP as well. He insisted that I take 40 milligrams of prednisolone and 2 tranexamic acid. Now, anything over 30 milligrams of prednisolone, I'm bionic bunny on 30 milligrams. 40 milligrams, I was climbing the walls that night. The tranexamic acid caused me some really nasty side effects. Normally when I have the nosebleed, I just ooze gently for between 4 and maybe 12 or 16, maybe even 24 hours. That's it. Well, even with a platelet count of 1.
Well, what I would say is,
what happened is that both sinuses filled up completely. And when I blew my nose that night, I have never seen blood clots like it come out. Not only that, I had thromboembolic.
What I would say is that your urinary tract infection, your 40 milligrams of steroid on the background of your imiflostin as well, will certainly explain your platelet count soaring.
That's good. But how does one refuse treatment when one knows one doesn't need it? Because I also had thromboembolic events in my feet. Yeah. And I recognize those because I've worked in vascular interventional radiology for 20 years, and I was in excruciating pain for 6 days. But the message from the consultant was I was not going to go home unless I took the medicine, and if my COVID test didn't come back negative, I'd be actually admitted to the COVID ward. Now, how does one go? Is it actually possible to absolutely refuse treatment? Because when my own consultant, so I had to go and see him the other day, the following day, because it was his day to come out and cover the district general hospital. He was horrified when he'd heard the treatment had been given because he would have left me alone.
No one can take any treatment that they don't want unless there's a specific reason for having to take it. And if he wasn't your normal consultant, then you were perfectly within your rights to say, I'm happy to sit in bed and tomorrow I will discuss it with Dr. Z. But I know that's very difficult. I mean, it's easy for me to say that, but you don't have to take treatment if you have reasons for not doing so, and you just have to discuss it. But that's a longer discussion. Thank
you very much, Karen.
Hey, thank you.
I think there's one hand up, and then
Mark Davis. Mark,
to wind up.
Oh, thank you. Yes, I wanted to put a quick question, if I could, to Adrian. So I was probably about 20, 25 years ago, I was diagnosed with asymptomatic ITP. I'd gone for investigations of a different condition, and my blood counts, I had sort of a succession of blood counts, I think, in sort of 70 to 120-ish range. Only ever had one sort of incident linked to ITP where, after a wisdom tooth extraction, I didn't sort of heal and stop bleeding at all promptly. But yeah, so for 20 odd years have been healthy and unsurprisingly apathetic about kind of keeping tabs on it. So I'm now sort of 51, you know, and platelets have been more in the news in the last week than they ever have been before, I think. Just curious to know, should I be being a bit less apathetic and making sure that I have a regular blood count done by my GP, and if so, how often would you recommend I should be being checked?
I mean, to be honest, we've been trying to move away from having regular blood counts, because people get obsessed with numbers and numbers fluctuate. So unless you're running counts to level or they're trying to balance treatments, there's probably less need to have a count checked on a regular basis, and you've had no treatment for years and you've had no bleeding and your platelet counts have been pretty reasonable. I would not recommend having a regular blood count because it just starts to engender anxiety. And I think that's quite a good, I mean, a normal person's count fluctuates on a daily, weekly basis. A patient with ITP's count may fluctuate, but of course, if you're starting at 30 and your count falls by 5, you get very worried. If your count's 180 and it falls by 5, you don't even notice it. It's only if the count falls in a regular way or you develop bleeding, and in general, unless you develop bruising or the little petechial little blobs, there's really not a lot of need to go and have a count, unless, as I said, you're stabilizing treatment. We just try to move away from this obsession with numbers. And I think the idea, probably what you've done for the last 20 years, is entirely correct. You know you've got a tendency for this, so you know if you go and see a physician or you have to be admitted for something, you can say, well, this is my condition, please check my platelet count before you do anything, just in case. But to have a platelet count just because you want to know the numbers, I don't think is a good idea.
Thank you, that's really helpful. Can I just sort of ask a quick follow-up? Sort of,
Sure.
Where I am at the moment with the COVID vaccine is I'm between doses 1 and 2 of an AZ. So, I mean, is there added value in perhaps having a current readout of my platelet count now, 2 weeks afterwards, the first jab, or not?
If you're having no problems, then I wouldn't. What was your last platelet count before you had you?
I think it was probably about 80 something.
Yeah. If you're not having a problem, I wouldn't. What I would suggest is that a week to 10 days before your next jab, go and have a platelet count, just so you know what it is, what the baseline is. So post-jab, if you ever develop a problem, you can have it done, and then you'll know what the changes are. But I wouldn't, if you're not having a problem, if you've got no bruising, no bleeding, no problems, then there's no real need to check it, to be honest.
Super. Thank you very much.
Thank you, Mark. Adrian, Maura's got a couple of questions. One, I believe we've already answered about could the flu vaccine be responsible for a drop in platelets, you know, which you did answer that earlier. But interesting point that a few people have raised. She's had the AstraZeneca vaccine in February and did have short-lived side effects, but nothing else. A second jab is scheduled for later this month. Should she be asking if it's possible to have the Pfizer jab instead? Now, this, you know, mixing of vaccines keeps being asked, and yeah. I know the latest advice is no, isn't it?
Yes, I mean, the 1 in 10 people get side effects with both vaccines. So the fact you've had it with, if you change the vaccine, doesn't necessarily mean you'll escape side effects. What I would say, and what some advice is to take a couple of Panadol an hour or so before you go and have your jab, and that certainly reduces the incidence of side effects, the sort of fever, that sort of thing. And I can certainly recommend that. I mean, I to be honest, I did it myself, and I've seen it suggested elsewhere. I didn't have any problem with my second jab. I had a bit of a I had a sort of night sweat with the first one that cleared within 12 hours. But just because you had a reaction with the first doesn't predict what will happen with the second, and changing the vaccine won't necessarily mean you won't get a problem. The issue of mixing vaccines, at the moment, it's not recommended. If you've started with one, you would have the same one second time around. There is some interest in actually looking at mixing them. Each vaccine stimulates a slightly different form of immunity. It hits something slightly different on the COVID virus. And there are studies going on now looking at mixing the vaccines and then measuring the response to see if that enhances the response. But that data is some way off being analysed and available yet. So you would be very hard to convince anyone to give you a different vaccine than the sort that you had first time around.
Thank you very much, Adrian. And I know we're coming to the end now, but Michael Cumberbatch. Michael, you got a question? You're on mute, my friend. Go ahead.
Well, two reactions, as it were, over the course of 10 years apart.
Can you speak a bit closer to the mic, Michael? We can hardly hear you.
Can you hear me now?
Yeah.
Is that better?
Yeah, we can now. Yeah.
I've had two ITP conditions in the past. Plus, I had sarcoidosis as well 10 years prior to that. Given that I've had sort of like 3 autoimmune reactions at different times, I know some of this has been covered already by the discussion, but would you still recommend going ahead and having a jab? Because I'm just rather concerned that I don't really want to be going back and forth to the hospital in the way I was with both times I had ITP. I was up and down to the hospital having blood counts done, and you know, it was a fairly nerve-wracking time, if you like, going through that experience. I don't really want to have to repeat that again, given I've had 3 different autoimmune conditions at different times.
Do you know what your platelet count is? What your platelet count is at the moment?
Well, I had a blood test, which is the routine blood test, about 2 months ago, and that came back about 140.
Yeah, I mean, there's really at that sort of level, there's no reason not to avoid the vaccine. The fact that you had problems with the ITP in the past doesn't necessarily mean you'll have to with this. The rate of the low platelet count post-vaccine is quite low, but compared with the issues related to COVID, then the risks with COVID are much greater than the risk of having a response to the injection. What I would say is that the sarcoid itself probably, presumably it affected your lungs a bit, did it?
Yes, right. My lungs were affected by it, yes.
Yeah. Well, certainly a COVID infection affects your lungs. You had sarcoid in the past would be a much more severe state of affairs, and I would recommend you strongly use that thing.
Okay. Well, thank you for that.
Okay. So sorry,
thank you, Michael. Thank you, Michael.
Answer, but and you may want to discuss it with your own doctor in more detail.
I must admit, when I spoke to my doctor very briefly about it, and I discussed and said to him about the issue with ITP, etc., he wasn't really that helpful, to be honest with you. I mean, you know, he really didn't give me much advice at all. Really, he just more or less told me to go and look at the government website.
Because he probably has little experience of it, to be honest.
Yeah.
If you've got more detailed questions, then you can always drop a line to the ITP Association to Mervyn, and we can look at it and maybe answer in a little bit more measured way.
Okay, fine.
Great stuff.
Okay,
thank you, Michael.
Thank you very much.
One last question, anyone? No?
Okay.
Well, I think, hold on. Lisa and Simon. Lisa's got her hand up. Lisa?
Time to wrap it up for me, please. Shortly. Yeah. Very quickly.
Lisa, last question.
Sorry, thank you, Adrian Newland. I'll be really quick. Our son is under 30. He hasn't been immunised yet. I was just wondering if there's a particular brand of immunisation you would suggest was more appropriate.
So you said he's under 30? He's
under 30. He's 26. He's had ITP since he was 2.
Well, he'd almost certainly be offered the Pfizer vaccine unless the Moderna vaccine is available, and it's only just starting to be used. But at the moment, he would be offered the Pfizer vaccine purely because of the potential, although unproven, problems with the AstraZeneca vaccine. But in general, the over 30s, you'll get what's available, under 30s are being offered something else.
Right, lovely. Thank you very much.
Thank you.
Okay, thank you, Lisa. Thank you, everyone. We'll call it quits now, I'm afraid. It's been a long session. Thank you very much, Adrian.
Okay.
Thank you, everyone, for taking part. Some great questions. Thank you, Rhonda.
Thank you.
Adrian, Derek, Anthony, superb. Lovely to see some of our local support group leaders here as well. Patricia, Karen, thank you, everyone. Take care.
Thank you. Goodbye, everybody.
Bye-bye.
Bye. Bye.
Thank you.
Bye, everybody. Cheers.